Hi, I was given the topic overview of the career pathway of internal medicine in Malaysia. Get my laser pointer out. Yeah. My main message for the day is that number one, we still need physicians. So you young ones watching out, please take note. If you enjoy solving the mystery, then becoming a physician should be a choice. You're going to be the diagnostician. The physician pathway as a career choice offers the most flexible, the fastest, the most number of subspecialty choices, and I think the longest workability duration, in my opinion. There are two pathways. There's a master's, there is the local program, and also the parallel pathway, where you sit for an exam that is from a foreign place, but you are trained locally. So you should choose one that suits you best, and I'll highlight both. So I'm also going to talk about who is a physician and why become a physician, and compare the master's and parallel pathway. Now, the term physician and internal medicine specialist and internist are, in my opinion, used differently in different parts of the world, but for our purposes, we'll look at it as similar. Okay, so a physician is a doctor who has got further training to be a better diagnostician who treats via non-surgical means. Sort of the best all-rounder, particularly the hospital. He is different from the primary care specialist because in primary care, you only do things in the clinic, you manage the clinic, whereas the physician is more attached to a hospital and will also have some clinic visits and clinic management. As with all other disciplines, general physician, when he encounters a problem that needs further expertise, then he will refer accordingly. So this is another picture of a very famous physician, William Osler. He said that medicine is a science of uncertainty and an art of probability. And I think it describes the job of a physician very well. You see, a physician should be able to tell when he sees a patient after being, let's say, admitted or seen by someone else, that this is diabetic ketoacidosis and not an acute abdomen. This limb weakness is not a stroke, but a hypoglycemic event. This is not a viral infection, it's scrub typhus. You are not sweating because it's hot, it's probably a coronary syndrome. You do not need to tap the pericardial effusion because you're having hypothyroidism. And we treat the hypothyroidism, you'll get better. You don't need a colonoscope for your diarrhea, just stop the metformin. This is not heart failure, this is pneumocystis cerebrale. So there are some of the examples where a physician, because of the way he was trained to make a better diagnosis, he'll be able to help the patient. Other plus points of becoming a physician: it has the most number of choices of fields of practice or subspecialties, including the new one for the advanced internal medicine specialty. At least 1/3 of this physician of these specialties are highly procedure-based, so it's suitable for those who are good with their hands. And if a physician maintains competence in general medicine, he or she can work until his or her twilight years, which may not be possible in some very highly specialized surgical disciplines. Throughout my talk, I'll be showing you pictures of senior physicians who have made a big difference to me, and this is Prof. John Bosco. These are the fields of practice under internal medicine. You can see there are many, right from cardiology to intensive care medicine. Now, the other thing, if you look at the number of malpractice suits against the different disciplines, you'll notice that internal medicine and family medicine is one of the lowest. So something to also think about when you want to choose your discipline. So in summary, guys, the physician pathway as a career choice offers the most flexible, fastest, and most number of subspecialty or fields of practice choices, and the longest workability duration. These are some of those who have made a difference to me. They're very senior, astute physicians. So another thing that William Osler said, that there are in truth no specialties in medicine, since to know fully many of the most important diseases, a man must be familiar with their manifestations in many organs. So this points to us that even though we have fields of practice in subspecialty, you must maintain your competence in general medicine. Now, going to the parallel pathway, these are the list of qualifications which you can use to present as that for you to be recognized and registered on the National Specialist Registry. If you notice, the first 7 are all the master programs, which are local. And then from then onwards, they are from Australia, UK, Ireland, Canada, American, Belgium, and the likes. Okay, so these are the ones. If you come with this qualification, you can apply to be on the National Specialist Registry, or we call it for short NSR. But please take note now. This first 7 are structured master's program, and there's no question about the coverage. If you have any of this, Australian, must be UK or Ireland or Canada, then there are further requirements. That's why it's stated here, all doctors with qualifications from 9 to the rest must show evidence of having at least 48 months of supervised training in internal medicine and internal medicine rated specialties. The maximum duration in recognition of internal medicine rated specialty will only be 4 months. So this is a very important point. Like MRCP UK or Ireland, you should consider that as an entry to specialist qualification. Okay? And that's how it's looked at in the parent countries as well, and similarly to us. So that is a type of summative examination that you must have. On top of it, you must show your evidence of formative assessment as well as training, where the duration is important, the 48 months. And if you notice, they're similar to the masters. And you must have the logos to show your coverage of cases along most disciplines of medicine. And it must be by trained supervisors, and there must be evidence of this formative assessment. For example, case-based discussions, mini CX, where you examine and feedback is given, how you could do your referral letters, and all-round feedback from your peers, your superiors, and also those who work under you. I will choose the MRCP UK pathway. MRCP stands for Member of the Royal College of Physicians, and exam. They have an exam, UK, as the example for all the other parallel pathways. You can imagine there'll be some differences between them, but UK one will be a good example to discuss. So remember that this qualification is an entry into specialist training. So there are 3 parts, part 1, part 2, part 3. You can sit for your part 1 after 12 months of postgraduate experience in medical employment. So you need to, after qualification, you need to work for 1 year, before which you can apply to sit your part 1. I'll give you details about what is part 1 and part 2. And then you would have heard from Prof. Edmund about the PACES exam, the practical assessment of clinical examination skills. And you must sit for this within 7 years of passing your part 1. So the part 1 exam assesses the candidate's knowledge and understanding appropriate for entry into specialist training. It can be online or in an exam center. It's 2 papers, Each is 3 hours and each contains 100 multiple choice questions in the best of 5 format. There's no negative marking. And the questions come from 14 disciplines plus pharmacy and on clinical science. That is on anatomy, biochemistry, physiology, immunology, statistics as well. Part 2, the format is similar to part 1, just that in part 1, there are no images, but in part 2, there may be questions about diagnosis, investigation management. It's emphasis on the ability to interpret information and to solve clinical problems. So the clinical scenarios, and hence you will have results, investigations, you have images, X-rays, ECGs, CT scans, and echocardiogram findings. And this is the PACES, how it's organized. There are 5 stations, and I think Prof. Edmund would have gone through with you in detail. And the important thing to remember is you don't fail a station. What you must achieve to pass is you must pass all 7 clinical skills, and you must have adequate minimum mark to pass to the exam. I won't go into detail about this. It's a very robust exam, and they keep changing, and there'll be a new format that'll be starting at the end of the year, but it's not very different. It's just made better. I put this up. You can see on the website the dates of the exams. You can look at the MRCP UK website date for exams. So these are the dates for the PACES exams. And the other thing I wanted to highlight is the cost. So if you sit in UK, it's £460. That's about 2,500 ringgit, depending on the exchange. And if you sit, let's say, in a center in Malaysia, or I think you can also sit in India, there are centers in Hong Kong, Singapore, and many other countries, then it will be £616. That's about 3,300 ringgit. So that's about the parallel pathway. Next, I want to share with you the differences between masters and parallel pathways, the similarities and differences. And I had prepared these slides when I was asked to do a debate between parallel pathways and masters. Now, when you have a debate, it means you must choose one. But must you always? My son always says both are also good. For everything, every question we ask him, you are like this or that, he says both are also good. And I was not told by the organizers of the debate which side to pick, but I'm a product of both. I have my master's locally, and I also sit for the MRCP UK. So what is the definition of parallel pathways? Basically, parallel pathways are any postgraduate qualification that is recognized in our country that is not in the master's as a local program. So that is parallel pathways. It must be recognized by MMC. So let me take you back history a bit about this masters and parallel pathway. The masters started somewhere in the early 80s. There was a national need for specialists, and hence they needed to have structured training for that. It's a national pride, has produced outstanding specialists over the years. Whereas the parallel pathway is older. The MRCP, I think, was founded in the 16th century. And for the parallel pathways, I use MRCP UK as a surrogate. Our previous colonial masters allowed some in Malaya to pursue this qualification, recognized in many countries, and produced outstanding specialists who subsequently became the teachers in masters. The masters is a 4-year program, structured program with a dissertation at the end. It's run together by several universities who form the conjoined board, and they have a large question bank, and it's very established in that sense. The parallel pathway, since the early 60s, is recognized as an entry into consultant training in Malaysia. And then to make it align with the masters, there was in 1994, there was a 12 months requirement after MRCP that you must, still be working under supervision, but now it's different. In 2000, there was a major meeting in Langkawi where it was made to 4 years to be similar to the masters. Even though you have this qualification, you must have that training as well. And then there's a logbook requirement in 2016. Masters can only train in recognized centers. There's this rotation to different disciplines, and candidates need to move where the rotations are taking place in different hospitals and different universities. The exams are fixed according to their time, and you must sit for it, and there's a scholarship most of the time attached to it. So there are rules of the scholarship as well. Whereas the para pathway, you can train where you are as long as a recognized specialist in your hospital. You need to make sure, even if you don't have rotations, you need to have that logbook to show the exposure of all the different disciplines, stroke rotations. And you can stay, therefore you can stay where you are. And you can sit exams when ready. And it's self-funded, there's no scholarship. So the candidates can prepare themselves to pay for the exam when they're ready. So in masters, then you have the professional exams in year 1, year 3, and then you have, and each one of it has a theory paper and practical examination, long case and short case. Again, recently, there's some changes to it, which I'll allude to later. The para pathways, as I mentioned, there's a part 1, part 2, and basis. So in the masters, there are multiple challenges because of scholarship. The scholarship is only for 5 years, and you must finish between then, that period. So it affects family dynamics, because during this period, after you qualify as a doctor, then you're going to go for the specialty or specialty training to be a specialist. That's the time you get married and you have children. So it can be very challenging now, especially ladies when they get pregnant, and sometimes they have to hold their training for some time. And then that affects the time that you have to finish within the scholarship. So parallel pathway is self-funded, so you choose your own timing. And the product we have, in my own experience, we have very good people from both pathways, and there are some with problem bonds as well. What about the cost? In the masters, the government pays about 16.5 thousand per year per candidate to the universities. So it comes about 80K over the 4 years. And they consider the salary that paid during that period to the master students as part of the scholarship. Whereas on the para pathway, most pass after about 1.5 times, and therefore, for the exams, part 1, part 2, and the basis, they end up paying about 18K. And many of them sit for their, mock exams across the country to get trained for the exam. So it costs about 25K. But remember, the other more important part, they're getting trained in the hospital where they are. So I asked a few of my own medical officers why they choose masters or para pathway. So for masters, they like it that it's structured. They think it's better training. Whereas in the para pathway, they say that I do not want to move from where I am. I take the exam and I'm ready. And once I make the payment, I'm motivated. So the other point that I want to make the difference is, for the MRCP part 1 is an entry-level exam, and you can only start to sit for it after 12 months of postgraduate experience. So after 1 year of housemanship, you can sit for it already. But for the master's program, about 3-4 years ago, they introduced the MedX exam, which you can sit anywhere in the country. There are several physical spots in the state where you can sit for it in each state, and it's a medical specialist pre-entrance exam, so you can sit for it anytime. So for the MedX exam, for the Master of Medicine entrance exam, again it contains 2 papers. Each paper consists 50 questions of 1 best answer of multiple choice, and it tests basic sciences, pathophysiology, disease, clinical scenarios that assess diagnostic acumen, medical emergencies, and common medical problems. So it's very similar to MRCP part 1. But, I thought things are changing. Now, the medical officers most of them are contract officers. A smaller minority have permanent posts. So the permanent post is like previously, you can, if you join the master's program, you get some sort of a bursary or even a scholarship. And while you're in service, you join the masters and you become a specialist. But the contract officer is a problem. See, they need a contract. So while you are doing a parallel pathway, you also need a job. So now they are coming up with scholarships which are tied to your training period. And hence the rules for that will come out soon. If you think about it now, then the parallel pathway and the masters are becoming similar to many ways. When you're subjected to this, the contract officer is subjected to scholarship, then you'll also have the rules of the scholarship you need to follow, which are not out yet and come in time. So the way forward, I see for internal medicine, we now have a national curriculum where whichever pathway you take, masters or the parallel pathway, the curriculum, what you go through, what are the competencies you need to achieve, the type of assessments are going to be similar for the formative part of it. Of course, the summative exams are different, the masters as well as the parallel pathway. Then we have now come up with MMC standards of specialty care that both the masters and the parallel pathway have to conform. My suggestion is if we make the masters more open, meaning that you can sit from anywhere you are and take it at your own time and only pay for the exams, then I think the need for parallel pathways may dwindle. I think when you have competition, it drives innovation, and we need to win via fair play. So our responsibility as doctors is to deliver competent care. There must be equity of care. And training does not precede care. Where there's good training, there's good care. And when there's good care, there's good training. So both of these must go hand in hand. So I will stop here, and the conclusion is, as my son always says, when given a question of making a choice, both are good. Thank you. I'll end here, and I'll take any questions if there are.
Thank you very much, Prof. Letch. Do we have any questions from the hall or online? For online participants, you can actually type in the questions in Q&A box. Any questions from the hall? Okay, hold on.
Is there someone saying a question? I can't hear it.
Oh, hello, Prof. I'm Shiva. I'm from one of the candidates here.